Hello. Welcome to our program, Digital Surgical Pathology, Slide Review and Sign Out. I'm Dr. Louis Hassel, professor at the University of Oklahoma Health Sciences Center, and our program is part of the Digital Anatomic Pathology Academy. We're glad you're with us. Our case today comes from the realm of GYN surgical pathology and has to do with a woman who was found to have a vaginal mass. She was postmenopausal, about 55 years of age. This seemed to be somewhat protruding into and rising from the wall of the vagina. She had no prior history of cancer or gynecologic problems. As this became somewhat larger, it became a problem for her. She sought attention. Well, the lesion on examination was found to be somewhat extrinsic to the vaginal mucosa. It seemed to have a fairly smooth surface. But as I think about lesions that can cause vaginal masses in a postmenopausal woman, I would think possibly condylomata if they're more distal, cystic lesions, especially more laterally, and occasionally, or perhaps most frequently, it's things that are projecting down from the uterus, polyps protruding through the os, and so forth and so on. These will often cause bleeding, and she did not have any of those symptoms. Various malignancies, of course, can involve the vaginal wall. These are also fairly uncommon. And then we have a variety of stromal lesions, including those that are so-called mammary-related stromal lesions that have analogs in the breast. And we've talked about those in some of our prior videos, such as hidradenoma papilliferum. Well, these are usually more vulvar, but of these lesions, fibroadenoma, phylloides tumor certainly could present in this area, as could myofibroblastoma. In addition, there are other primary stromal lesions that enter into consideration as well. So since this was not too large, the surgeon opted to do a resection. As you can see here, still fairly sizable and somewhat of a lobulated pattern, areas of higher cellularity, lower cellularity, not a very epithelial appearing pattern, although there is some cording of some of the cells here, and I apologize that the slide is not cleaner. We do have a fair bit of artifact here. But as you can see, these cells are somewhat cohesive. There's a bit of a spindle-shaped cell pattern here. And there's a very minimal, if any, atypia or pleomorphism in these cells, and a moderate amount of intervening stroma. Looking at the vessels, as that's always a consideration in this location, various angiomatoid lesions or aggressive lesions. We'll see that most of the vessels here are sort of these small to intermediate-sized capillaries and arteriolar type cells or type vessels. There's no large caliber, no gaping vessels in this lesion at all. And it's fairly uniform across the entire spectrum as we look at this. So we did a battery of special stains, of course, because that can be quite helpful in evaluating these lesions. So the stromal lesions that we think of in this area, of course, include the aggressive angiomyxoma. That's the one we really don't want to miss. We can also have cellular angiomyxomas, myofibroblastoma, which we've mentioned, so-called angiomyofibroblastoma, and then more esoteric lesions or common lesions like leiomyoma, and then less frequent lesions, solitary fibrous tumors, et cetera, et cetera. So we've discussed several of these entities in the past, and this particular chart was helpful to review. The discriminating immunohistochemical stains in this location that can help us are Desmond to demonstrate smooth muscle type of differentiation, CD34, which can be quite nice to demonstrate the vessels, but also can be positive in some of the stromal cells in certain lesions, hormone receptors, smooth muscle actins, and then a few specialized markers like HMGA2, RB1, STAT6, and so forth can be helpful. In our particular case, this lesion turned out to have positive Desmond staining, some positive CD34 staining, and positive hormonal markers. Additionally, it was positive for CD10 and totally negative for STAT6. which is an important consideration if we're thinking about CD34 positive lesions here to rule out solitary fibrous tumor. Of course, we didn't have the characteristic ropey collagen or the patternless pattern type of thing in that as well. So superficial myofibroblastoma of the mammary type is a benign spindle cell tumor that has a loss of RB1 expression by immunohistochemistry. It's part of the family of tumors with loss of this allele that can include so-called spindle cell lipoma, which is essentially the same thing, as well as some other benign entities. And then, of course, that loss can be associated with more serious malignancies like retinoblastoma, especially if it's a germline loss. Interestingly, the morphology in these lesions can be quite variable with areas of myxoid change or decidual change and so forth, including lipomatous tissue that can be included in these. There really is no atypia, as we've indicated, no necrosis, no mitoses, although rarely heterologous elements have been reported. And the immunohistochemistry I've already gone through. Now, the most frequent location to encounter this lesion actually is not in the vulvovaginal areas, but is actually in the breast. And so I thought it might be useful to include a representative sample from the breast. Here we can see a few breast structures here for comparison. And here this nicely sharply circumscribed lesion with, in this case, a little bit more epithelioid morphology. But you can see there's a bit of spindle cells, some collagenous tissue. Again, the fairly uniform small vessels, no particular gaping vessels, no atypia, no mitoses. Here we have a little bit of fat, perhaps, in this lesion as well. And I think you can see it's a fairly bland lesion. So these surgically in the breast are no big deal, but when we encounter them in the vulvovaginal area, they may occasionally present some challenge in terms of surgical removal. And so proper discrimination from the more serious lesions like aggressive angiomyxoma is very helpful to do. So our final sign out on this case is myofibroblastoma of mammary type, a benign disorder that does not require additional therapy or significant follow-up. And the patient will hopefully suffer no untoward consequences from the surgery because the tumor itself is not at all life-threatening. Well, we hope you enjoyed today's program, and that if you did, that you'll give us that like button. And please leave your comments. We welcome suggestions for future topics you'd like to see covered, questions you may have about the issues that we present and discuss here. And of course, we always are grateful if you want to be a subscriber to our channel and receive early notice of future releases.